Okay, good afternoon. Welcome to Grand Rounds today. We have two talks, as is the usual routine, both very clinically relevant, right after a very good ASCO for patients for Yale. We thought we'd highlight a few of the issues that were discussed there. And for the first talk, it's really my honor to introduce Dan Petrylak. I think most of you know him. He's a professor of medicine, and he's the clinical research program leader for prostate and urologic cancers. And one of his main research interests, as many of you know, is bladder cancer. And I'll tell you how, since he arrived at Yale, about a year and a half ago, 2 years ago now, wow, time really flies, he really has built a program in a number of different areas, including bladder cancer, seizing on our phase one triumphs to bring that into this very difficult to treat disease. So Dan, welcome.
Roy, thank you. It's certainly a pleasure to present this data. So I'd like to just sort of set the table and discuss metastatic bladder cancer. We know that nearly 75,000 people will be diagnosed with bladder cancer in 2014. This is predominantly superficial disease, almost akin to what you see in prostate cancer, where most of the disease is localized. This will result in about almost 16,000 deaths from metastatic disease. It's predominantly in men, about 11,000 in men, about 4,000 in women. And this is the fourth most common cancer among men and the ninth most common cancer death among men. There are basically several different types of bladder cancer, but the predominant ones are urothelial carcinoma, which represents about 90% of the cases, and that's what this discussion will be focused on. Squamous cell carcinoma, 4%, and adenocarcinoma, 2%. And this is a tobacco-related malignancy. Smoking is a risk factor, as well as chemical exposure. Particularly the dye industry, that's where you see the greatest incidence of bladder cancer as far as an epidemiologic issue is concerned. The treatment of metastatic disease has been somewhat problematic. This is some long-term data that was published by Scott Saxman in 1997. For a long period of time, single-agent therapy was felt to be the best treatment, and as you see from the left-hand column, it's not particularly active as far as long-term experience is concerned. Of 122 evaluable patients, only 4 were alive at 3 years, and then 2 were alive at 6 years. Contrast this in the randomized trial to the MVAC regimen, which was invented by my late mentor, Dr. Alan Yagoda. 3 years, 17 patients alive, 9 patients alive at 6 years. So this is a little bit better, but we of course, need to push the envelope and improve treatment. And this, for a long period of time, was the sole standard of care, MVAC. Gemcitabine and cisplatin is considered to be an alternative standard of care, and this also is long-term survival data that was published by Dr. van der Maas. This was compared to MVAC, and as we see here from this trial, the patients who do better are those who have lymph node-only disease. Those who have visceral disease tend to do worse, and the survivals are still just about the same, about 15 months as far as MVAC is concerned. We consider both to be equivalent standards of care, but I think it's also important to point out that the trial that compared gemcitabine cisplatin to MVAC was not an equivalence trial, and in fact there is the possibility that MVAC could have been superior in that study. So as we see from these trials, the majority of patients will progress after initial response. And this is the data with salvage therapy. It's somewhat disappointing, actually it's extremely disappointing. We don't see that any agent emerges as being effective. Pemetrexed has a response rate of about 27% in the hands of Dr. Chris Sweeney from Harvard. The taxanes have activity, but no agent has been shown to improve survival in this particular setting. And in fact, in Europe, vinflunine, which is a vinca alkaloid, it's approved for second-line therapy, but this was approved based upon a randomized trial that compared it to best supportive care. And there was a slight improvement in survival that was actually non-significant when you look at the first analysis, but when you start censoring the data and taking out patients who came off too early, and I think that's a bit of a fudge, there does seem to be a benefit. It's really no better than what standard chemotherapy is at this particular point, and it's not approved in the United States as second-line treatment. So where do we move from here? How do we improve the treatment of metastatic bladder cancer? Well, I'm going to outline several approaches that we're taking at this particular point. So we know this is a molecularly heterogeneous disease. The Genetics Network published a paper in Nature this year showing that there are multiple pathways that are altered in bladder cancer, but there's really no one pathway that stands out as one that we should go after. And this is an issue because unselected trials, and this may explain why we see these low response rates, they're unlikely to yield positive results, and if we can enrich our trials and enrich our patients, we may be able to improve therapy. One target that we've been pursuing, and this has been an active collaboration between the phase 1 group with Paul Eder and the GU group, has been looking at the anti-PD-L1 antibody. And we know that this inhibits the binding of PD-L1 to PD-1 and B7.1. These are regulators of T suppressor cells, and this can restore T cell immunity and activity and enhance T cell priming. And as we see here, this is from this cartoon, that's where those are the blocking areas. And this has been evaluated. Roy has been a pioneer in moving this forward in lung cancer. But overall, it has a 21% response rate in 175 patients. This includes non-small cell lung cancer, melanoma, renal cell carcinoma, sarcoma, ovarian cancer, head and neck cancer, breast cancer, colorectal cancer, gastric cancer, and lymphomas. And the important thing is when you start looking at the tumor-infiltrating immune cells and looking at immunohistochemistry, we see that those patients who have high levels of expression in their immune cells of PD ligand, these patients will tend to respond. IHC3, 83%, score of 2, 14%, 1, 15%, and 0, 20%. So you do see some baseline responses even in the low expressing patients, but the ones who do the best are the ones who have the high expression rates. And we see a lower rate of expression in the tumor cells, but again, a overall lower rate and a similar pattern. So if we start looking at human cancers and looking at both the tumor cell as well as the immune cells, we see that about a quarter of non-cell lung cell immune cells as well as tumor cells will express it. Renal cells, we see renal cell carcinoma is, again, the same thing, about a quarter. Melanoma, they all seem to be about in the same range as far as the tumor cells and as far as the immune-infiltrating cells. It's somewhat lower in colorectal, pancreatic, and gastric cancer in the tumor cells themselves. What about bladder cancer? If you look overall at the tumor cell rate, it's about 11%, and the immune cells is about 27%. And this is a representative stain from a patient with metastatic bladder cancer. The left side represents tumor-infiltrating cells, and the right side represents the overall tumor cells. So, as we saw from before, in bladder cancer, this is a high unmet medical need. We don't have, in the United States, an approved therapy to use second line. If you look at PD-1 expression, we know that the immune system is active. In radical cystectomy specimens, about 45% of those specimens will express PD-1 in the tumor cells. And we know from previous experience that BCG does have activity in superficial disease. So this is a disease that potentially is immune responsive. And if we look at, remember that previous slide that we saw before with the genetic mutations, we know that this has a high mutation rate of complexity, and this may be again related to the tobacco exposure as well as the chemical carcinogens that cause this tumor. Finally, look at the graph on the right. This disease has not had its day as far as GU tumors are concerned. Prostate cancer has had 5 drugs approved since 2010. Renal cell carcinoma has a panoply of drugs approved as well, and there hasn't been an approval in bladder cancer in advance since MVAC and gemcitabine and cisplatin. So this is our clinical experience. We opened the protocol in March of 2013. And as I mentioned before, this is a collaborative effort, and I think that one of the unique things about this institution is how people work together and how there's good cross-fertilization between groups. Overall, at our institution, we screened 67 patients, and 14 patients were eventually treated on trial. So this was a multi-center trial, and this is the data from all centers. The median age, as one would expect, is in the 60s from bladder cancer, predominantly male population. ECOG performance status about split between 0 and 1. A fair number of patients had visceral disease, 75%. Liver metastases, 30% overall. And these were a heavily pretreated group of patients, with 93% in the immune system or the PD-L positive patients having cisplatin therapy. The negative patients is 61%. Carboplatin 23 versus 43%. So they practically everybody had prior chemotherapy in this particular trial. So what I think is most striking about the anti-PD ligand antibody is the fact that the toxicity is really minimal. And think if we're giving gemcitabine or cisplatin, or if we're giving docetaxel, or if we're giving pemetrexed, there's really no neutropenia, no neutropenic fevers, and the major side effect that we see is fatigue and decreased appetite. So it's been very, very well tolerated. There were some patients who did develop, one patient who did develop thrombocytopenia and hypophosphatemia, but there were no grade 4 or grade 5 AEs, and there were no immune-related toxicities that were reported at the time of the analysis. So this is our response rate if you look at the immunohistochemical analysis of the immune cells. So if you are IHC or IHC3 or IHC2, your response rate was 43%, and 1 or 0, it's 11%. So think back to the slide that we saw before, where our response rates were pretty poor with cytotoxic chemotherapy. If you really don't express the anti-PD ligand or the PD ligand, you still have a response rate that's comparable to what you see with standard therapy. So overall, there were 2 complete responses, one with an IHC of 2 and one with an IHC of 3. Again, this is unheard of in this disease state, and the median follow-up was 4.2 months. We still do not have any progression-free survival data or overall survival data at this point, but 16 of 17 patients continue to respond after the data cutoff. So this is the waterfall plot of the responses in bladder cancer. As we see, the red and the orange represent the low levels of expression in the immune cells, and the green and the dark gray represents unknown. But as we see here, the predominant expression rate is 2 to 3, but we still see patients with 1, 0, and 2 who have responses, albeit not somewhat as profound as you see with the stronger staining. So this again is an indication that the target is there. It's active and working, but there are no other comparable trials with cytotoxic agents that show this type of response pattern. Now, what about the rapidity of the response? And this is also fairly dramatic. When we look at the responders, the median time to first response was 42 days. And it ranged from 38 to 85 days. We have not reached the median duration of response overall in our patients. So these are a couple of anecdotes from the 3 major accruing centers. This first is a 68-year-old male who was treated from 2011 to 2012 with BCG, radical cystectomy, and then cisplatin-based therapy. He relapsed after treatment in a retroperitoneal lymph node, as we see here. This was PD-L1 positive, and this patient had a response to treatment. And although there's no prospective data looking at circulating tumor cells in bladder cancer, unlike lung cancer and breast cancer and prostate cancer, they did detect them, and there was a decline. And this was the staining from this particular patient in his immune cells. This is a second patient who was at Yale. Was our first patient that we treated. This is a gentleman who had been on gemcitabine cisplatin, docetaxel, as well as pemetrexed. And he had a large supraclavicular lymph node. He also had retroperitoneal adenopathy. And as we see, after 6 cycles, this is pretty much gone. He is now durable more than 1 year since his initial response. And we have 2 other patients like that at this particular time. This is a patient who was treated in Spain, had a metastatic lung lesion, had a cystectomy and gem cyst for his metastatic lesion, and then he relapsed after a 4-month treatment-free interval and had a complete response to treatment. Now, we have also a very similar patient here at Yale. In fact, this gentleman was a complete responder at his first assessment about 45 days after his initial treatment. And the interesting thing about this patient is that he had systemic BCG as a vaccination. And there may be some correlation between BCG expression and PD ligand overall expression as well. We start looking at circulating immune markers. They tend to peak at the second cycle, interferon gamma, IL-18, as well as CD3, CD4, and HLA-DR. So these do increase, and these are an indication of activated T cells. So in conclusion, this is clinically significant activity in heavily pretreated patients with metastatic urothelial carcinoma. In the positive patients, it's a 43% response rate, and these responses to date have been durable and ongoing. It's been well tolerated. Only 4% had grade 3 or 4 toxicity, and there were no grade 4 or 5 events. And there are additional studies that are now being performed. We're going to be opening up a large phase 2 trial at Yale, hopefully the first week of July, and this will hopefully confirm the data that we've seen in the phase 1. So what are some of the critiques of this trial? So the staining that was obtained from these patients, or at least the tissue, could have been from any source. And this could have been from a radical cystectomy. It could have been from a metastatic lesion. It could have been any of those particular sites. So the tissue may not have been reflective of the immune status of the patient at a given time. These patients could have been treated with chemotherapy. They could have been treated with other agents, and that may have actually altered the expression. And that may be the reason why we're seeing a discrepancy with the staining. Consecutive biopsy specimens were not obtained, so we don't know what goes on in the immune system, how it upregulates itself, what are the markers of response and resistance. This is the phase 2 trial that I mentioned before. There's no requirement for positivity. All patients are going to be having tissue collected prior to their administration of the drug, and we're going to treat overall 330 patients, predominantly cisplatin refractory. But this is a group for which there is no medical standard of care, platinum ineligible patients. Generally, we'll give gemcitabine and carboplatin to this group of patients who have poor renal function, peripheral neuropathy, hearing loss. But this is actually a group to really study upfront treatment with, and not second-line therapy. Again, it's an unmet medical need. So this leads us to a trial that is going to be done at Yale. We're in the process of designing. We've actually got approval from Genentech to go ahead with this. This is for platinum-ineligible patients, and as we know, neoadjuvant therapy is standard of care for those patients who have locally advanced bladder cancer and are cisplatin eligible. But there's no standard for those patients who are ineligible for platinum. And what has been found is that there's really not a huge difference if you delay the cystectomy by 6 weeks in the overall survival, and that's been shown in multiple retrospective trials. And because of the fact that we saw before that the responses are fairly rapid, this gives us a unique opportunity to look at the effect of the anti-PD ligand antibody on tissue, and then, of course, response in bladder cancer. So the standard of care is to do a transurethral resection of the bladder, and then we would give the investigational agent up to 4 cycles of the anti-PD ligand antibody, and then they would go on to standard of care, which would be radical cystectomy. So we'll have specimens to compare both pre and post, and of course what we hope to see is a fair amount of pathological complete responses, but we're going to be doing immune monitoring peripherally as well, so that may give us a clue as to how to further develop this treatment in patients with metastatic bladder cancer. So in the final moments, I'm going to talk about another approach that we're moving forward with, angiogenesis and anti-angiogenesis agents, and we should have some data within the next year as to whether this is an active approach in this disease. We know that higher levels of angiogenesis in primary tumors are associated with poor prognosis, particularly if you see a neovascularization in the primary tumor. VEGF gene expression is increased and correlates with higher stage progression and prognosis in patients with bladder cancer, and also this is correlated with vascular invasion and grade. We have been looking at monoclonal antibodies to anti-VEGFR2, and it's been found in vitro that these may be chemosensitizing agents when given with taxanes, and this has been shown in bladder cancer cell lines. And the VEGFR1s may also inhibit metastases based on the fact that it interferes with this particular pathway, and also it interferes with hematopoietic growth factors. So ramucirumab is a VEGFR2 inhibitor. Ipilimumab is also a VEGFR1 inhibitor. They hit different receptors, and this is one way that we potentially can dissect out the effect of these drugs on bladder cancer in our clinical trial. We know that VEGFR2 is expressed in bladder cancer, as we see from these particular sections. Here's a TCC. This is normal bladder. This is normal bladder as well. It's not expressed. It's not expressed in the prostate, at least in normal prostate, but it's expressed in the stroma as well as in the tumor. So we've just completed a randomized phase 2 trial that we were the lead institution on. Lilly sponsored this. 3 arms, 138 patients overall. We now have completed accrual, and when in the follow-up stage, docetaxel ramucirumab, docetaxel ipilimumab, and then compared to docetaxel alone. And I hope that we'll have this data by next year. Finally, we are in the process with the Alliance. In my role is the bladder cancer chief for SWOG. We are doing a collaborative trial. This is actually Jonathan Rosenberg's trial. I'm going to be looking at correlating some of our molecular techniques with this, particularly exosomal expression of some of these agents. 3-arm randomized trial looking at FGFR expression and an FGFR targeted agent, RB targeted agents, as well as PI3 kinase agents in the second-line setting. And this again may fill a niche in those patients who are not necessarily responsive to PD ligand. So in conclusion, immune checkpoint inhibitors are active in patients with advanced bladder cancer. VEGFR2 inhibitors synergize with taxanes in the laboratory and are potentially second-line agents for urothelial carcinoma. And then in the future, now that we have some agents and leads, optimal combinations and sequences need to be defined. Thank you, and I have 5 minutes for questions.